So very good afternoon and a warm welcome to this instruction course. I'm talking on behalf of Dr. Gaurav Luthra, who will shortly join us. So Oops moments in refractive surgery and managing them appropriately. So this wonderful course has been showcasing nationally and internationally. The chief instructor is Gaurav, and we'll be talking about different situations in refractive surgery, how to handle them and how to manage them. आ गया Thunderbolt.
So very good afternoon, everyone. And today's course is on Oops moments in refractive surgery. And I've requested Dr. Sonu Goyal to take the opening batsman's role. And he will be speaking on refractive surprises after laser vision correction, what to do.
So thanks Gaurav for making me part of this course. So I'll be sharing one of our interesting case that we recently accidentally happened with us. This 26-year-old girl had a refractive error of -8 with 0.5 SIL, 180 degrees, and the routine investigation, as we do for all refractive surgery patients, were done. The PECI was close to 553 and 557, indirect ophthalmoscopy, MS39, LipiView, epithelial mapping, the Claris pictures, this is the topography, the pentagram pictures, and this is MS39 and the eye trace, and this is the macula, the fundus photograph. So everything was done, the patient was planned and discussed, and the patient wanted a lenticle extraction. So we took this patient on the Smile Pro with a cap thickness of 110, minimum lenticle thickness of 15, and an OZ of 6.2. So this is how we proceeded with the surgery. This is the Smile Pro, and routine docking once the patient interface has been docked in. And this is how the wonderful center align and the ocular-align system helps us to align both the cylinder and the center on the visual axis. Cut, the lenticle cut, side cut, the cap cut, cap side cut, entire process taking around 8 seconds. A routine dissection that we follow, I usually use this sharp dissector, separating the two planes, going first underneath the cap. I'm sharing this new technique that we have devised. This is called the inside-out technique, and courtesy to Dr. Gaurav Luthra as well for teaching us the hydro expression. So what we do differently is we go underneath the lenticule and leave two stumps from 10 to 2 o'clock, which remains undissected, and push in. This is the two stumps left here and here, and we push in a small jet of BSS, and the lenticule comes inside out. From 6, it expresses out, and then we can slowly pull in. And the beauty is that it gives you in toto the lenticle extraction, hardly any patient of 340 eyes that we did. So what this patient had to give us on day one, they expected was 20/20 both eyes. Fortunately, in the left eye, the patient got 6/6, but unfortunately, in the right eye, the patient had 6/60, and we took this patient for the entire gamut of diagnostics, where the refractive error on day one was minus 5.25. So for a patient fixing for -8, the residual was minus 5.25 with some amount of residual cylinder as well. So this refractive surprise for all these patients that you do, check in for refraction, you check in for your epithelial mapping, tear film analysis, wavefront abarometry, topography, tomography, OCT. So the entire gamut of tests were offered. What surprisingly, during this, we found out that the fellow who had recently joined us, instead of feeding for the right eye -8, she said, I misread 8 and 3, and she put in -3. So the clear undercorrection came up with us. Now the patient was a little fussed. He had to travel abroad. So he had a period of 7 days. We discussed with all the options, gave him an option to come back to us after 3 months, and then we could do it. But then we reviewed literature, how early can we do this? So the enhancements options after myopic smile, this wonderful article in the APO speaks of all the options available. Though the enhancement rates after smile routinely are very low, but this was a Oops situation. So we thought of discussing with the patient and working on the 4 different options: the PRK, the femtosecond LASIK, secondary smile, and the circle. So we discussed with the patient about the PRK, but since on the PRK platform, it was a -5 diopter error, and we had made a cap of 110, and since the patient had to travel, so though this was the easiest way, but when you are taking enhancements on the PRK platform, pain and delayed wound healing and a little haze that can, expect could be there because you're using a mitomycin C on top of a smile patient. So we didn't err in favor of PRK, again discussed with the patient, so the downsides and the advantages, and a quick look onto the literature came up of a concept of what is called as a secondary smile, where you actually do no anterior dissection, but just push in a posterior dissection and remove this. Since the whole concept was new to us, we did not err for that also, and we went in for what was called as the circle. So enhancement for smile, converting the cap, we thought we could convert into a flap, and we planned this patient for a circle enhancement. So the recommendations of the circle, as is the inner diameter of the lamellar cut should be approximately smaller than that of the existing incision. The overlap should be large enough, and the upper and the lower depth of the junction should be chosen so that the possible depth range in which the edge of the existing incision could lie, taking into account the these were the 4 different patterns, but the pattern D is the most commonly which is being used. So this patient was then taken after a week on the circle. The refractive error remained unchanged. The epithelial map did not give much of changes. So we planned on the 7th day, and so this is how the circle software helps in. This is the docking on the Pro platform, and hardly 4-second procedure. And the essence is basically converting the cap to a flap. And once this was taken, the patient was then moved on to MEL 90. Once this, just watch very carefully, only the peripheral rim has to be separated, because essentially the cap has already been separated once the lenticle has been removed. So very, very carefully we separate this, and now this cap, so-called cap now, a flap can be lifted, and the patient was then shifted to MEL 90, and the excimer was done. So this was how we were able to address the outcome, and the patient could regain 20/20 the next day. A quick word for all the cautions that we thought of. So the most important thing is feeding in the right data, accurate refractive measurements, accurate patient selection, patient ruling out thin corneas, high refractive errors, corneal irregularities, dry syndromes, Intraoperative factors are very, very important because there could be some errors with flap thickness, decentered ablations with the excimer. When you have a surprise, there could be cap-related issues. But for me, the oops could be with the fluctuations, the energy fluctuations in most of the excimer platforms. So the temperature and the humidity and the hydration of the tissue is one very important factor which could give you that day one oops in most of these refractive patients. So moving into the literature, we just came in with one good idea, and this was a concept that when you relift for the flaps, chances of epithelial ingrowth is usually very high, which ranges between 2 to 43%. So femtosecond platform on a retreatment is very important, and the flap diameter should be 1.2 millimeters smaller. The flap should be around 10 micron thicker than the original peripheral flap thickness measured by the anterior segment OCT, and the side cut angles taking 90 degrees with the hinge angle, the hinge being at the same place and the hinge angle at 50 degrees could help in preventing this one of the disastrous complications. So as you see here, this was one of our own patients where we did a retreatment, we did raising the flap, and you see how bad was the epithelial ingrowth. So in such situations, the dictum is quite easy. You need to relift the flap, and you have to take care of the epithelial ingrowth, which is stuck most of the times onto the bed and the undersurface of the flap. So carefully debridement of the epithelium here, and I use the blunt surface of the 15 blade and gradually remove all the epithelial debris from all around, and I also scrape 360-degree the epithelium so that there are no further chances of the epithelium getting inside, and then we address the undersurface of the keeping it launch and very carefully removing the debris of the epithelium. I usually use alcohol for few seconds onto the bed and then wash and then replace the flap. Drying for some extra seconds is a good idea whenever you're trying to relift the and putting a bandage contact lenses. Sometimes you can use sutures if you feel, and this is how the day one picture looks like. Thank you very much.
Wonderful, Sonu. You've kind of summarized so many things for us. But I had a question for you, and I wanted to ask you that has your management for enhancements over a prior LASIK, changed over the years? Like, what were you preferring to do 10, 15 years back, and how do you want to do it now? Has there been any change? Like, would you like to go on the surface, or you always like to do a flap lift? What's your preferred way, and has there been a change over the years?
So I think it depends upon the primary procedure done for all the smiles that we have done, though we do not have any long-term outcome since we've been doing smile for the last 5 years. Hardly find any patient where the enhancement was actually required. But yes, since we have circle, and for minor diopter, maybe half or maybe one diopter, I would do a surface on top of a smile. Otherwise, I would err in favor of the circle and then taking the patient onto a excimer-based system. For most of the LASIK patients that we have, unless and until it's a major dioptric surprise or enhancements required, I would still relift and very carefully, as documented, take precautions so that there is no epithelial ingrowths, and do a LASIK flap relift and enhancements. For PRK, again, PRK gives a good option for any low dioptric correction, and that's specifically for those kind of fitness patients that we have done maybe a couple of years back, and they still have a residual of half, or when their re-medical happened in their the services, they would come to us with some kind of a regression of maybe half a diopter, one diopter, where they have been, made unfit on their existing jobs.
Excellent. And do you look at the epithelium maps when offering,
So
and what's the
yes.
significance of looking at them for a LASIK or a PRK
So
enhancement?
I think that's a very valid point, and epithelial map is mandatory. We have that MS39 equipment with us, which actually gives you the thickness of the epithelium, and sometimes it could be an ectatic cornea or a keratoconus, which is kind of masqueraded by the abnormal thickness of the epithelium. So it could be some kind of a abnormal epithelium, which is actually causing that refractive error. So at times it could be just the dry eye. So I think all in all, epithelial mapping in today's world, whenever you have a surprise or whenever you have kind of a residual refractive error, is mandatory in all these patients.
It's if there is a hypertrophic epithelium, as you said, with the MS39, you can get a thickness of the epithelium as well as the epithelial refraction as well as the minus the stromal refraction. If it's essentially sometimes if it's just the epithelium which is hypertrophied, I would even just debride the epithelium, wait for it to
Very true.
regrow and see,
Yeah, yeah, yeah.
reassess what is the refractive error and then
Yes.
decide.
That's a great idea. And I mean, adding some lubricating drops and just waiting for a couple of months and then rechecking the refraction and rechecking the epithelial map, or just simply debriding the epithelium works very well in these patients.
Thanks a lot, Sonu. That was really useful. Please come and join me, and I'll invite Dr. Ramamurthy. And we are lucky to have Jodhbir with us, and he's talking on a great subject, which is very much to my liking. So we'll have him on next. Dr. Ramamurthy, sir, does not need an introduction. Actually, he's been the scientific committee chairman of AIOS, one of the most successful ones, and then the past president, and so on and so forth. And he is speaking, he's a dear friend. He's going to speak on dealing with the unhappy, dissatisfied smile or LASIK patient. And please go ahead, sir.
Thank you so much, Gaurav, for this kind invitation to be a part of your course. I think I'm just going to be showing a clutch of situations. Residual power after any refractive surgery, one of the pain points for any patient as well as the physician. And once you have done a smile procedure, we have been doing smile for almost a dozen years now. And then it's not just smile, but it's Clex today with multiple platforms that are available. And before the circle became available, it was essentially PRK that we used to do. We used a streamlight, and it is a continuous initial debridement of the epithelium. Usually we take the epithelial measurement and feed that inside, and the thickness of the epithelium is taken off, and subsequently the power is corrected. Usually the amount of power that is left over is quite small, and mitomycin C is invariably placed in all these eyes for a 0.02% for a period of 30 seconds. And with that, a contact lens placement, 3 days later the lens comes off. It used to work quite well, and I'm quite happy with the results. But then of course these patients have to undergo through the pain, irritation, discomfort for a night, which usually is concomitant with a PRK procedure. Then of course now we have the smile procedure. I'm not going to go into the details of how it is done, but it's a the smile cone is given to you by the company, and you can see that it works very well. Basically it's converting the cap of the smile procedure into a flap. So the advantages of having a very minor incision is lost, and you are having again back to almost a 300-degree incision. But it's the advantage of this is a painless procedure, and as far as the patient is concerned, it's a little more comfortable. But we were getting excellent results with PRK also, and in case it's just about a 0.5 diopters which is bothering the patient, as Dr. Sonu also mentioned, I would not hesitate even today to go ahead and do a PRK, simply because I don't want to lose the benefits of having done an initial smile where I could do the entire surgery with using a very small incision. Coming to the more important aspects which make the patient unhappy, like a retained lenticule segment. This was a walk in the park case, you minus 1.5 diopters of spherical error in one eye, and minus 2, and post refractive surgery on the first post-operative day. She was a young college girl, and she was extremely unhappy. Minus 2 with minus 3.5 diopters of cylinder is the refractive error that she had. Fortunately, the other eye had done well, and actually she had the lenticule was taken out in fragments, and my colleague thought that she had taken out the entire lenticule, but this was the refractive error. And on topography, which was done, mind you, this was done on the first post-operative day, you can see this classical bow tie over here, which corresponds to the amount of refractive error that is there. And then, so we decided that it could be a fragment of retained lenticule, decided to go ahead and try to remove this. And you can see that the initial opening being opened up, and usually it's stuck onto the back of the cornea. Since we could not visualize this, we have subsequently published on this also. We are using diluted triamcinolone acetate, and immediately on using this, you can see this getting nicely demarcated over here. This is actually the lenticule fragment, which is right there in the center cap, and that's being peeled off and that's being brought out, and then subsequently you can wash this off. I think using this diluted triamcinolone is a good tip in the sense that it delineates any lenticular fragment that's left over quite adequately. And this is the topography. You can still see some amount of irregularity, but the bow tie that you saw completely disappeared. And the first day post-op refraction itself, after the removal of the lenticle fragment, was 6/9 with a fairly clear cornea. Obviously, the triamcinolone in the eye also would have helped to reduce the inflammation. This is that first one I showed was my own case, rather done by a colleague, and I took out the fragment. But this was a case which came from elsewhere, not referred to us, but the patient had been following with the primary surgeon for some time, but was very unhappy with the outcome. And this was the primary refraction according to the records, that minus 2.75 and 3.75. Left eye had done well, but right eye, uncorrected visual activity was 6/36 and best corrected visual activity was just 6/18. And my optometrist recorded a very irregular reflex on refraction. And as you can see here, the multiple pointers, we could not get the full history. Whenever you have faced with a situation like this, it's always a good idea to look at the primary surgery video in its entirety, and very often you can find out as to what exactly went wrong. But in this case, we did not have access to that video, and you can see the difference in the curvature. Here it's almost 45, while it's 40, and this area is suspicious. This is somewhat bulging forward, and if you and this is what I wanted to highlight, 45.8 and 40, and you can see the epithelial, the stomal thickness map, and you can see is 542 and 491. So this is a significant difference. So this makes me suspicious that something might be left over there, and you can see in this anterior segment OCT that this is the possibly the lenticule fragment that's left over there. And just with the dilated examination, in a slit lamp examination, you see this rugosity, while this area seems to be quite clear. This is made me suspect that this could be an area where the lenticule had been left over. We are not the primary surgeon. This is running at twice the speed, and basically I am not using the triamcinolone acetate. I would have used it if I had not able to identify it. But my initial attempt to take out the lenticule fragment itself worked, and I could identify the lenticule fragment in the area where I suspected, and you can see that being peeled off from the posterior aspect of the cap, and that's the fragment which was doing the damage, which had primarily, whenever a patient has a problem like this, a refraction like this, it's a good idea to look for this and remove it if necessary. Oftentimes looking at the primary video, it also give an idea as to what went wrong. So this was the way the patient presented to us, and this is what subsequent to the removal of the lenticule fragment, you can see that the uncorrected visual acuity has improved to 6 parts with a fairly regular cornea. Ectasia as such is considered to be quite low compared to, especially if a case selection is quite appropriate. But then because of the huge number of CLEX procedures that are being done today, this is rearing up. This was a fairly high dioptric correction that was done in the year 2015. And today, if I had a refractive error like this, I would go ahead and do a phakic intraocular lens, even though the SMILE is capable of handling this kind of a refractive error, simply because the stability of results that we get with a phakic lens. But at that time, I had done a SMILE procedure for this patient because the cornea was quite regular, the thickness was quite adequate, the bad D maps were also quite good. And this was in the left eye, which has a slightly lower refractive error, but very similar thickness as well as bad D maps. And then The patient went off to the Middle East and then came back. Initially, she had good vision, but that subsequently came back with a drop in vision. And you can see a very irregular cornea with a -6, best corrected visual acuity as 624, and a full-blown iatrogenic keratosis, which is inferiorly located. And very thankfully, the left eye, which had gone exactly the same procedure for a slightly smaller refractive error, had maintained good visual acuity. We, we went ahead and did a intact procedure with collagen cross-linkage for this patient. This is primarily the way it's done, and then the channel is created. At that time, we are using the intralace for doing this, and then you can see the intact segment being positioned where exactly it should be, and this is the subsequent collagen cross-linkage that's done. And basically with this, what happens is that the cornea gets regularized, the decentered cone becomes a little better centered, and most importantly, the refractive error, the best corrected visual acuity improves from 618 to 6/6. I'm not so bothered about the amount of refractive error that's left over, which has also reduced incidentally. But the more important aspect is the reduction, the improvement in the best corrected visual acuity, which we are able to achieve. So we waited for a period of 1 year. Nowadays, I would do it just for 6 months because I'm quite comfortable with this. That was in 2000, almost 10 years back. And you can see that the difference map shows good stability of the the correction that was achieved. And at this time, we went ahead with a phakic intraocular lens implantation. And you can see that implant being put in place. So essentially, the patient presented with the iatrogenic keratosis post-smile. We initially handled with Intacs and CXL, and after regularization of the cornea, we went ahead and did a phakic intraocular lens. That's with the post-operative picture, with the intact segment, with the phakic intraocular lens in place. And very surprisingly, 10 years of follow-up now, 5 years post-surgery and 5 years, the left eye has remained pristine and with no refractive correction at all. And it's the same, two eyes of the same patient. It's just that it's slightly less correction. So there's a lot that we do not understand about iatrogenic keratosis still. And this is just one index case for that. Epithelial ingrowth post-smile can be bothersome, especially it's quite rare compared to femtosecond flap-based procedures. But this can be disruptive, and especially if it's centrally located like this, the patient can be quite uncomfortable. So essentially what I'm doing here is to go ahead and debriding this, and we had waited for a period of about month's time, and when this was bothering the patient, I think I have topographic maps also, then subsequently just debrided from the back of the cap as well as from the stroma. Here obviously you cannot lift up the cap, so we did use 20% diluted alcohol to essentially deal with whatever epithelial cells that were left over. And this is the post 1 day photograph. You can still see some haze over here, but then it has significantly improved. The visual acuity also improved quite well. Then DLK post-smile, it's again considered quite rare, but it can occur, and where you can see me going through the primary incision itself and giving a wash so as to wash out whatever debris that's there, because it was a grade 4 DLK with a drop in the visual acuity. It's essentially handled similar to what you do with a epithelial ingrowth. And epithelial defect, this was actually the patient said that she did have a minor trauma in the first post-operative day itself. It could have been induced during surgery also, but this is what we saw. Basically, we just patched up the eye, rather put a bandage contact lens, and within 3 days it healed up well. Apart from that, the usual complications like dry eye, infectious keratitis, transient light sensitivity syndrome, I'm not going to the details because I think I run out of my time, but then these have to be handled on their case merits. These are quite rare. Dry eye, of course, is possible, though the incidence is slightly less compared to flap-based procedures, but just in case you come across these symptoms, they have to be handled appropriately. Thank you so much for your kind attention.
Thanks, Dr. Ramamurthy, and that was quite an elaborate, talk on unhappy smile patients. I'll invite Jyot to take stage because we are running out of time, so I think I'll ask for a couple of questions and you can set up your presentation. I wanted to ask you, sir, and maybe you can join me here itself. Sometimes we have these smile patients whom you see that they look amazing and, everything looks perfect. You check their autorefs, they're almost plano sphere, plano cylinder. Everything is great and you think that, you've done a great job. And then the patient will say, but I'm not happy with my vision. And this is not just right in the beginning. Sometimes this will happen like even 3 months to 6 months down the line. And then you're at your wit's end, the epithelium healing is happening properly. You might just see a little bit of a, maybe slight decentration or something at the most, which you won't wonder whether it's accounting. Have you dealt with such patients and then what do you do?
Yes, this is a problem that we are faced with all kinds of refractive surgery and cataract surgery also. Obviously, we'll look for dry eyes, and that's frequently a cause. And once you treat that adequately, it helps. Sometimes there's higher order aberrations that are left over that could be bothering the patient. It's also occasionally not meeting the patient's expectations. They are bothered by the glare and halos, etc., which obviously it's a young patient with a very large mesopic pupil that could also be a concern. But we do once in a while come across this.
Yeah, sometimes you try everything and then nothing seems to work. Thank you. So I'll have Jodh speak next, and he's all the way from Singapore, one of the most prolific speakers, and he's been doing lenticule for more than 10 years, as I understand, and has done amazing amount of work. He's speaking on optimization of your lenticule for KLX, a very interesting topic.
Thank you, Gaurav. Thank you for the invitation to partake in the course as well. Okay, so I'm going to be talking about optimization of lenticule for KLX surgery. So when we look at KLX in 2025, of course, we have many machines now that are available in order to do this procedure. DICE basically have the new VisuMax 800, Schwind have the ATOS, Zima have the Z8 with the clear procedure, and J&J have the Elite procedure that produces silk. And you see from this table over here, there are many differences, or there are many subtle differences amongst the machines itself. But today I'm going to really just focus on one of these, and this is basically the lenticule shape. And what you'll see is that most of the machines will generate a lenticule that is basically plano convex in shape, but the Elite system generates a basically bioconvex lenticule. If you look at this from the schematic, you can just basically see this in detail with respect to the lenticule shapes that are basically created. On the left-hand side, the biconvex shape with the Elite. On the right-hand side, really pretty much most of the other companies make some kind of concept shape with this, but they're not all quite similar with respect to their plano convex curvature. If you look at the lenticules that are created, and this is done in a human donor eye bank study, and then you do OCT, you will see actually when we compare the Zima on the left-hand side compared to the VisuMax on the right-hand side and do OCT sections and then measure the thickness, there is a difference in the actual lenticule shape configuration between the two machines. Typically what you can see is that the side cut on the VisuMax is between 15 and 30 microns. This is typically, this is a 15 micron one on this side over here. But the lenticule shape in the Zima, for example, goes down to a side cut angle of basically 0. And that's why you get this difference in this diagram below over here in this figure, where you can see there is a slight difference in the shape, even though it's overall a plano convex shape, but there is subtle differences within the lenticule configuration itself. So when we consider lenticule creation, there are really variables that you need to basically think about. One is the cap depth. Second is optical zone, obviously the incision size, the side cut, and the centration of the lenticule itself. This is just looking at the lenticule formation. I'm not going to talk about energy optimization and nomogram adjustment, that's a whole separate area itself. But presuming you've got already your energy adjusted and the nomogram is basically adjusted as well, you still have these variables for where you see every patient itself. And then over the next couple of slides, I'll show you how you can work out what's the best way of basically programming the laser in order to get the best outcome for your patients. So let's take this one by one. Let's look at incision size. Why do we always go for basically a small incision? So really this is going to be dependent on your experience basically in lenticule procedures itself. If you've done a lot of lenticule procedures, I would never start off with a small incision, maybe start off with a 3 or 4 millimeter incision itself. But as you get more experience, I'll try to reduce that incision size down, and typically, routinely I use basically 2.1 millimeter as my standard incision itself. Why do we do that small incision? This paper from basically John Marshall, now published over a decade ago, basically looked at the effect of basically making a lamellar cut or a vertical incision side cut. And what you can see from over here is that the weakness in the cornea itself comes basically from that vertical incision cut, not from basically the lamellar cut in the corneal stroma. So however big your basically vertical incision is, whatever size you make your incision size itself, that's what's going to basically contribute to the biomechanical weakness of the cornea itself. So the smaller, basically the better itself, okay? If you make 2, even if you don't open 1, as soon as you've broken through Bowman's membrane, you're going to basically weaken the cornea itself, okay? So ideally try to go, when you get more experience, keep on dropping the sight angle down, basically try to open it to only 2 millimeters. What about basically optical zone measurements? Now, when we program the laser, this is basically what the optical zone that the surgeon is basically programming. Okay, when you look at the effect of the biomechanics on the cornea itself, this is what we call basically functional optical zone, and that's related to the biomechanical response. What we know from this study from Dan Reinstein basically showed us is that if you look at this increasing size of basically the optical zone of patients from 6.5 to 7, you're going to basically get an increase in the amount of spherical aberration induction. Okay? So what that means is for the same dioptric treatment, if you basically have a smaller optical zone, you're going to get basically more basically spherical aberration. Right? If you can basically increase your optical zone, you can basically cut this down. Of course, the downside of increasing the optical zone is that you're going to eat more tissue up to basically do the ablation treatment. So you need to basically take this in consideration of other parameters. So how does this relate to centration? Okay, well, the way you can link your optical zone to centration is that if you decenter the lenticule by more than about 335 microns away from the centration point, again, you're going to basically, from the corneal vertex, you're going to introduce spherical aberration induction. And that's why your centration has to be as close as possible onto the basically corneal vertex to reduce the induction of spherical aberration. So you have 2 parameters, centration and optical zone size itself. And I'll show you how you can apply this clinically in the clinical examples I will show you. If you basically decenter the eyes, and this is basically the group 2 over here with the open circles itself, not only will you induce high-order aberrations, you will induce basically vertical coma, spherical aberration, and you will also basically induce, there's a chance of inducing horizontal coma itself. And this is related to decentration irrespective of the optical zone that you will use. So decentration alone will have a higher induction of basically all your aberrations in the cornea. If you look at this as in relation to optical zone size, even though the correlation coefficients are actually not that high, they are statistically significant. And what it tells you is that, again, decentration is relative to basically optical zone. So if you have something that is basically a pupil or an angle kappa that is more decentered, a way of negating this is by increasing your zone size. Okay, and this will help you get around those difficult situations. The fifth thing to look at is basically cap depth. Okay, why do we want to go basically deeper? Remember, you're going to do a smaller incision, so you're going to reduce the biomechanical effects. If you go deeper into the cornea, you're going to be able to get a faster recovery of the ocular surface itself. And typically, on a routine case, I'll go 130 microns basically depth. This will increase the speed of recovery on the ocular surface. However, you need to balance this with respect to the RSB, okay? And of course, if you go deeper than basically 130, like 140 or 150, you will definitely need to do a nomogram adjustment, because the deeper you go into the cornea itself with an infrared beam, you need to basically do an adjustment of the amount of stromal tissue you're basically going to remove, because you're going to basically go deeper to remove the posterior cut as well. For shallow anterior caps, which is often what we have to compromise on and use basically in patients with moderate to higher degrees of myopia, obviously you have a higher risk of getting a cap edge tear because your cap is basically only 100 microns thickness. Okay, so these are the basic principles to think about when you're basically thinking about how you're going to program the lenticule on every single patient. And then I'm just going to basically show you some examples of basically how we do this. So let's just take this patient to start with. She's a 27-year-old male gentleman. Anti-segment, posterior segment is normal. Basically does sports, the investigation officer in the police. If you look at the refractive error over here, it's low myope, minus 350, a little bit of astigmatism, very good vision, 64.5. If we look at the tomography readings over here above, you can see pretty much normal tomography. The Corvus data down below over here shows basically normal basically TBI and normal basically BADD readings as well. If we look at the left eye, again, very similar kind of pattern, a bit more astigmatism on this side, but basically normal basically biomechanics on basically the TBI side as well. If we look at basically the angle kappa, what you can see is that the kappa intercept is larger on the right eye and absolutely dead straight in the left eye. So what does this tell you? So this tells you that basically I'm a little bit concerned about the larger angle kappa on the right side. It's not too large, because I can tell by the readings over here it's only 0.4 on the intercept itself. But whatever I do, my optical zone is going to be larger on the right compared to what I can do on the left. Now, the corneal thickness in this patient is quite good. It's around about basically 540, so I can be a little bit liberal, and actually I can do a large optical zone on basically on both sides, and that's exactly basically what we did. So what we did in this situation, this is when I used the 800 VisuMax laser. I did 130 micron cap on the surface because that gives me the optimal ocular surface recovery. I don't need to worry about RSV in this example, and I basically did a treatment with a 6.7 millimeter optical zone basically in both sides. This is with my nomogram adjustment and with basically the energy optimized on the laser. This is the 1 week visual acuity result. Okay, so you got a good visual acuity result. I don't need to worry about the angle cap on this side because I increase the optical zone basically to 6.7. Let's look at another case. Okay, 26-year-old guy again, very similar age group. But this time you look at a very high myopia, right? Minus 9.75. This is very common to what we see in Singapore with a bit of basic astigmatism, minus 850 on the left-hand side. Let's have a look at the tomography. So tomography based on the right eye essentially looks pretty normal. The Corvus data below over here also basically looks pretty normal. Corneal thickness around about basically 560. So kind of like borderline really on how we're going to basically push this limit. So you know already we're going to have to do some adjustment on parameters in order to basically get this guy to be able to do a lenticle extraction basically procedure. If we look at the left eye, again, very similar basically pattern over here. BADD looks quite normal, and your TBI, basically biomechanics, also looks normal as well. But because he's a high myop, I automatically know his corneal incision size is going to basically be 2.1 millimeters as well. Let's look at the angle kappa. Now the angle kappa over here, you can see, or the kappa intercept on both the scans over here, on both sides, slightly more deviant on the right eye compared to basically the left eye over here. So you can see this on this side over here. So what it tells me is that I need to adjust the angle kappa to make sure I get a basically good refractive result. But of course I cannot go too big here now because this is a high myopic treatment, so I need to basically do the high myopic treatment. So I need to compromise on something here in order to basically do the treatment. So what do we basically do? So what we did was that we use a 100 micron cap. So I basically tried to give myself the maximum level of basically myopic correction. Because the angle kappa was slightly superior over here in the left eye, I wanted to make sure I incorporated this into basically my optical zone. So I use a 6.3 optical zone treatment on the left-hand side. On the right eye, I use a 6.0 optical zone because I thought I can get it absolutely bang on centered because the angle kappa was closest to centration on the right eye compared to what I could see on the left eye itself. Okay, and I compromised a little bit on the left-hand side. And also remember, you have to make sure you have enough RSP. So I had over basically 300 microns RSP on both sides on the right and basically slightly less on the left side because I increased the optical zone on that side to incorporate the deviation in the angle kappa because it's slightly more superior, and with the 500 laser it's a lot more difficult basically to do the centration compared to basically the 800. Okay, so this is your compromise that you need to think about when you're doing the programming. So when we see basically the outcome, so one day outcome pretty good, 7.5 plus, this 9.4. When we basically see them about 1 month, so pretty good now. The visual acuity is basically picked up from both sides. But remember, because it's a high myope, you have to treat the ocular surface very aggressively because I've compromised on the fact that I want to do a laser vision correction treatment when they're with a laser. So I know as a high myopia, I'm going to basically induce more dry eyes because I've compromised the cap to basically go to 100. So you aggressively have to treat them with ocular surface with cyclosporine, topical eye drops, and basically give them plugs and omega-3, basically flaxseed oil capsules as well, in order to basically pick up the surface recovery because you know they're going to have delayed recovery because I've compromised a little bit with my lenticle size by having a 100 micron cap there itself. So you can tell them that straight away this patient will have an immediate plug put in at 1 week to basically help them with the ocular surface recovery. So in conclusion, successful lenticle requires optimization of many parameters. Okay, it's not just the energy. Obviously, you need to think about your nomogram adjustment, but when you're thinking about the lenticle itself, the parameters are basically listed over here. Your cap depth, your incision size, your optical zone, and your centration, and your side cut side are going to basically affect the outcome. And you can need to tailor this for every individual patient that you will see itself. My default would always be 130 microns at 6.7, but I vary that depending on pupil size, depending on many of these parameters that I basically showed you as examples basically today as well, and to basically achieve the best outcome for the individual patients. So you do need to customize yourself, and this is in addition to the customization of nomogram adjustment, and obviously the idea is by doing this you can improve your short and your long-term outcomes. Thank you for your attention.
Very nice, Jodhpur, excellent. So please join me, and I have 2 questions for you, and I'll invite Raghav to take over and speak, but I'll have two quick questions for John. Raghav is going to be speaking on oops moments and smile procedures, and I'll request you to try to stick to about 5-6 minutes because we are a little bit behind schedule on this and we have 4 more speakers. But John, two questions for you. One is that you did mention about if you have to change the cap thickness, you would like to apply a nomogram for the correction, number one.
Yeah.
So what would that be, for example, a 100 micron cap versus a 150 micron for some reason if you wanted to do that? And the second question is, would you rather for the same correction, suppose you're removing a lenticule of say 100 microns plus, would you rather leave a thinner cap or a thicker cap as far as biomechanical strength is concerned?
Yeah, so the nomogram adjustment needs to really start to occur if you go below 130. So if you're going basically like 140, if you're doing whatever you do for 130, you can do basically for 100. So if you're going to go like 140, 150, 160, I mean, I don't ever go that deep in so then you need to do a slight adjustment and stuff. You need to increase the amount of correction you need to do. So if you're going between 130 and 100, you don't need to do the adjustment. That's the first thing. The second thing, the second one was...
Second is that what is biomechanically more strong, a thinner cap or a thicker cap for the same correction if you're removing a thick lenticule?
So if you're removing a thick lenticule, remember the weakness, like I showed from that paper, comes from the vertical incision. So the first thing is always try to do a small incision that's safe, depending on how much experience you have with the lenticule itself, okay? Whether you're going to basically remove that lenticule from a more anterior side, so it's a 100 micron cap or a 130 micron cap, it's going to have a direct effect on the ocular surface recovery. So from a biomechanics point of view, obviously you'd think that basically if you basically try to maintain the more anterior side, it should be basically better. However, the caveat to this is that really most of the evidence has only really been shown in high myopia that there is some basically advantage in SMILE compared to basically say the LASIK itself, right? If it's a really biomechanical issue and you can do, I've still basically put first choice within self-observation, and in those cases where I'm a little bit suspicious, I would basically do that. But remember, your weakness really comes from that vertical incision, so I try to make that as small as possible when you do it.
Thank you, Joe, and lovely talk. Thank you so much for sharing your pearls, and I'll request Raghav, who's again a very good speaker from the Center for Sight, and he's going to be speaking on oops moments in SMILE.
Thank you, sir. Thank you. I'll just briefly present my talk on oops moments in KLX. So my talk is going to be basically based majorly on SMILE, since we've got more number of cases on SMILE, so therefore more complications we've seen over the past decade. So what we need to know is that basically there are 4 cuts in any KLX procedure: a posterior cut, a cap cut, a side cut, and a main wound. So we can have a suction loss at any of these cuts. So general points to avoid a complication in a KLX would be, of course, to treat any ocular surface, because if there is any untreated MGD, there will be cold spots, which can lead to lenticular levenants. Secondly, take care not to overexpose the cornea. We don't want the cornea to have exposure keratopathy. If we do have that, we are going to have some cold spots again. Thirdly, dry the conjunctiva, moist the cornea. That's very important. If we have pooling, we can have a pseudosuction. Lastly, delineating the planes is the most crucial part. If you can find the anterior and posterior planes, so more than half the battle is won. So the issue at hand is actually majorly just finding the right plane. So there are some signs that have been elaborated in literature that help us actually finding the anterior and posterior plane. I'll go through them step by step. The first is the meniscus sign. So when you use your dissector to find the anterior plane, very important to go up. Once you go up and you follow the roof of the cap, you will go nowhere but in the anterior plane. Otherwise, if you do zoom in and do magnify, you can see there is a small meniscus made by the lenticule. So if you see this meniscus is going above your instrument, you are in the posterior plane. But if you feel that your instrument is above that line, that means you are in the anterior plane. It can always show the small hole showing where your instrument has entered. Secondly, you have the white ring sign. Again, you see that white ring whenever you have crossed the anterior plane, and similarly you can see this at the other end of the lenticule. If your instrument, if this line is going above your instrument, you are in the posterior plane, and vice versa. Again, the stop sign has also been elucidated. So basically that means that once you go, let's say, to the left onto the anterior plane and you do half a dissection, similarly on the right side you go into the posterior plane and go towards the left. So you will see a certain resistance. This resistance means that you are in different planes. That very comfortably shows you have gone once in the anterior and once in the posterior. If there is no stop sign, that means you are in the same plane. So if this is a case where there is an absence of a stop sign, so you go up you go towards the right and you try and form the anterior plane first. So this is the anterior. And then, so this is actually we want to go into the anterior, but we've gone to the posterior. If you actually zoom in, you'll see that the instrument is going below this line. Now you go and try and find the posterior, you will see that there is no resistance. That means you're in the same plane. So if you find that a line of resistance, that means you have gotten both your anterior and posterior plane. Now, this is a quick video. I'll just show that if you do an AIOS2025 guided KLX, you will be able to see where your instruments are going. So once I take my dissector inside, if I pause here quickly, so you see that I am in the wrong plane, I am in the posterior plane. If you see this sandwich, this is my lenticule, this is the cap, and this is where my instrument is. So if I would have gone and taken the anterior plane, my instrument would have been in this plane, between the cap and the lenticule. So this is the posterior plane. And now if I go into the posterior plane, what you will see is, as soon as I enter, here, I'll pause here. So you see now this is the cap and this is my instrument and this is the cap below it. So that's the anterior plane. So now suction loss is something that is dreaded for every refractive surgeon. So the incidence of suction loss is more so in SMILE because the suction pressure is much lower compared to other platforms. So it's about a 25 to 30 millimeter of mercury. If you have a suction loss, if the patient moves, if your cornea is overhydrated, having a suction loss is very easy. Of course, the SMILE also gives you the advantage of knowing what to do next. So there are some guidelines what to do if you have suction loss at what step. Like I said, during the lenticule cut, that is the posterior cut, if it is made less than 10%, you can restart. If it is more than 10%, you have to convert that into a femtosecond flap, but you have to increase the diameter of the flap. Thirdly, if it happens during the lenticule side cut, you can repeat the side cut. If during the cap cut, you can repeat that, and similarly, if it happens from the main wound, you can repeat the main wound also. So this is a gamut of videos that shows that if this is the posterior plane, and here we have the suction loss. So this was more than 10%, so we had to convert this into a flap, and making that into a flap using the Circle software is pretty easy. So not the Circle software, but you can just make the femtosecond flap using the VisuMax. Now going on to a video where you have a suction loss during the anterior plane. You can see this is a high cylinder patient, that's why the geometry of the laser cut was like that. Anyway, you have the posterior cut, and now during the anterior cut, we are going to have a suction loss. Once you have that, not to worry, the VisuMax will give you an alert. It will tell you that you can use the IR for centration and actually make the anterior cut again. So you can wait for half an hour, have the OBL go down a bit so that you can make centration, and once centration is done, so it was very easy actually, so you see this is the anterior cut being made again, and then the surgery is pretty much routine after that. Now if you have a suction loss during the side cut, so this is of course something really, really unfortunate that you have the side cut during that particular cut. So you see this is the side cut being made, and that's why you have a suction loss. So you can decrease the diameter and actually redock and make that lenticule again. Now if you have a suction loss during an entry cut, this is most unfortunate, this is the last part of the surgery. If you have a suction loss during that time, then you have another couple of options. So you have the posterior cut, you have the...
Raghav, I'll have to request
Yes.
you to summarize because we are running short of time.
Okay, so I'll just give you a last thing that yes, you can have a remnant lenticule. If you have a lenticule and you have dry spots on the cornea, you can have an uncut area of lenticule left. You can diagnose that using an AIOS2025, or you can stain with triamcinolone and also fluorescein. So this has been described. You can use the AIOS2025 to see a remnant lenticule, and to remove you have two options. One is of course you can first you can stain, then you can dissect, or you can also use a circle scan to make a flap and then remove the lenticule. So this is the evolution of refractive surgery is heading towards closer and to better vision and to better biomechanics. Relax is the latest technique, but since it is still, rather not say infancy, but yes, in its adolescence, you can have complications, but not to worry, these complications can very well be managed. Till date, no complications or very few complications other than actually lead to vision damage. You can manage them very well. So we can, if you have the right technology and the experience, they can be managed timely, giving very good results. Thank you.
Thanks, Raghav. That was very nicely done. And I'll now request Dr. Ajay Sharma sir, who's chairman of the IQ group and a wonderful cataract and refractive surgeon, to go ahead with his talk on, he's going to be speaking to us on OOPS moments in refractive lens exchange surgery. So please go ahead, sir.
Good afternoon, everyone, and thank you, Gaurav, for the introduction. Uh, we all know that today the cataract surgery as such is a refractive surgery because we want to have a perfect results post-operatively. But there are certain moments, certain patients where we do a refractive surgery only when even the patient doesn't have much of a cataract. So historically, the thing started way back in 1776, and first systematically performed RLE was in 1890 by Vincennes, and then with the introduction of the lenses, the things became very easy. Now, refractive surgery, as I said, is associated with the lens opacities, refractive errors and lens opacity, especially in presbyopic age, especially high myopes, more than 10 diopters, hyperopes, more than 5, and patients more than 40 years of age, they are the perfect, the presbyopic and hyperopes are the perfect. Advantage is just the same surgery as we all do, the cataract surgeries, and disadvantage it's a intraocular procedure and chance of retinal complications are more in myopes. And preoperatively on, we have to do the same workup and all what we do. It can be done in myopia, hypermetropia, astigmatism, and amblyopias, but in myopia, when we have to take in certain contraindications, which you see here, that there should not be more of the retinal complication like peripheral lattice degenerations, young eyes with no posterior vitreous detachments, and presbyopic eye with macular degenerations and all. And these can be the complications, because this is before having a OOPS moment, we should know what all can happen during the surgery. So retinal detachment is the most dreaded one, and definitely when it happens, it is mostly post-surgery, and it has to be dealt by our retina colleagues. And then there can be a macular degeneration, edemas, and all those things. Similarly, in hyperopia, we do these surgeries, but we have to take care because there is a small hyperopic eyes and shallow ACs are there, and they are more predisposed to close angle glaucoma. And this can be complications, can be PCOs, which are more in hyperops and secondary post-op IOP rays. And it can happen in children, astigmatism and all. Now, this is something which we all should know. Special consideration is in high myopes, we know there is a depth and stability of the anterior chamber is abnormal, so which necessitate the use of dispersive viscoelastics. And eyes with excessive axial length, there is risk of perforation and choroidal effusion in hyperopic eyes. So just to show just a normal refractive lens exchange, it is just like a normal surgery. This is a post-femto case, and removal of the nucleus should be done very nicely, and low pico power modes are very important here. Because if you see here, it is just only the vacuum which we are creating, and with that vacuum, we can take out the nucleus. But you have to be very careful, because even at low vacuums, you have chances of rupture of the posterior capsule if you are not proper, again, in managing or handling that. And then we take out the cortex, and implantation of the lens as such is there. Certain things which can happen is, one most common is when if the pupil is constructing, there can be a small pupil, and with these lenses which have four closed haptic design lenses, though it can become very difficult. So see here the lenses, I'm not able to push the lens inside. I tried maneuvering it inside, but then we did a bit of a dilatation, and after we dial the lens, after a dilatation of the is done with the mydriatic, so we can see the lens going inside. The one haptic goes inside, and this one goes inside, and then the second haptic goes inside. Now that is done, but at the end still you need to check. So I'm rechecking it with the second instrument, whether the haptics are inside or not. This is the PC red. Now this is the most dangerous thing which we will encounter, especially in refractive lens exchange. Patients are young. Now I have done everything, implanted the lens, but when I am doing the IA, I just found now this. What is this? This is the capsule I have got here, and this is, I never realized that there has been a rent, and so now we have to manage. Now this is a patient where I have implanted a pure C, which is a toric lens, and I have to keep it in this direction. So dilated again with the intracameral phenocaine, and now I have to take the lens out because it was going down from the place where it was, and now so I took it out, kept it in the AC, and then I am tucking the two haptics. I didn't have any choice, but I have to put it in the sulcus, though it is a single piece lens, not advisable, but still this is what I did, and but again, and I have to keep it at an angle where, because it's a toric lens, so after that, and fortunately it was there and there was no problem. Later on, patient had a good 6/9 vision next morning, and after 15 days the patient is doing wonderfully well. But definitely we have to keep a track. Now this is something on a subluxated lenses. You can see this is a catalyst machine. We can see the surface mapping, and here you can see the dislocation, clear cut dislocation here. Now we have to be very careful while we are operating, and here we have just cut the lens into 4-5 fragments, and then we are taking the capsule. We are doing a very good hydro because, and rotating the nucleus inside because that is needed, and once that is done, again with a very slow vacuum, the nucleus is taken out. You see there is no movement of the tip of the phaco, and you can see how nicely this has been taken. Now this is something, and we have to put the CTR, and then the lens was put inside, and the patient is doing very well. Now this is something very interesting. This is post ICL refractive lens exchange, because most of the patients now which got the ICL done, now this we tried with the femto, and we saw the surface mapping, we could get the anterior surface, but again the posterior and even all this was not there, so we need to do it manually, and which can be done in a catalyst, and here we are doing the things manually. Just the last one, and we did it manually, and it was nicely maneuvered. You can see the ICL here, and in second case we just tried the femto, and immediately it took over, and then we just did the surgery here, took out the lens, and a routine phaco surgery was done, and again you can see how nicely just with the vacuum we are doing the phaco surgery. I think we can stop it here. Thank you very much.
Thank you, Dr. Ajay. Before Gaurav starts his talk, I just wanted to ask you, like, in a refractive lens, may not be ready for a need of, often they may want great distance, intermediate and near, and you end up putting a trifocal. Would you think of doing a mix and match, giving one kind of lens for one eye, or would you do a micro monovision in these young guys? How would you deal with it? Would you do either of one eye and do a micro monovision?
So I think as I said, the counseling part is again very important, telling the patient about each and everything, and trifocal lenses with the halos and glare, these patients are young patients and most active life, and so they don't probably want to go for those lenses. EDOFs are the best for them, and especially the refractive one, the Pure C, which has come in as a boon for such patients. So I'll prefer that, and mix of micro monovision definitely can be done in these patients.
Thank you. Thank you very much for a detailed talk. We go on to our next speaker, Gaurav Luthra. Who has put together a very good instruction course, and he is going to be talking on AIOS2025 in phakic lens planning. And we have come to understand that just injecting a phakic IOL into the eye is not enough. There's a lot more in the pre-op planning and also in the post-op.
Thank you, Dr. Chitra ma'am. And I wanted to share a few cases. This is like, I pulled out this case from 2005 when I first started doing ICLs. And so it's been almost 20 years, and it's been a long learning. So you can see that when we started doing ICLs, we were not so sure that, this was amongst the first 3 cases. I was not very careful. I didn't know how to deal with a situation like this. I was doing probably a wound-assisted injection. My incision was 2.5 or 2.8, but, I probably didn't have enough counter pressure, so the ICL got stuck. And now I didn't know at that time that how you're supposed to deal with it. Today it would be so easy to just kind of pull it out, and you can see that I'm struggling whether to let it go in or out. And now I'll just show you how this would have happened recently. This was a patient where we were doing the same thing. You can see enough counter pressure and everything, but for a moment you lost that pressure on the eye, and now I'm having a stuck ICL, and today I would just tug on it and bring it out. At that time I remember struggling it for a good 15 minutes, and eventually I pushed that ICL in. Luckily nothing happened to it, but I was doing it with a Hoskins and it was horrible. And when I look back at that, I wonder how I actually did it, but it was like my second or third case at that time. So going on, this is another situation where I've loaded the ICL, and just watch the ICL now. It just went back all the way. This almost never happens. This happened only like a few months back, and I found it really interesting. I thought I must tell everyone, because what happens is that if your ICL is loaded correctly and you hold it very close to the tip or the nozzle of the cartridge, it usually won't go back. But here it did, and it's very important because when you now try to put it, if you don't notice this for long enough and you just go and load it and push the plunger, the ICL, one of the haptics of the ICL will get stuck, and when you are injecting it, it won't come out. So now I typically pull it there, watch it for a moment and see that it's stable. Then I put it into the injector and make sure that it doesn't, push back on its own. So this was again a learning thing, and I thought I must kind of convey this to everyone else. This can sometimes happen. I'm injecting, just watch carefully. I make a small adjustment as it's opening a little funny. I rotate my cartridge a little bit, but as I inject, it still rotates further. And now I'm having to stabilize it with I do a wound assisted injection under infusion. So my left hand already has an infusion on, and I'm now stabilizing it, because if I leave it, it'll just twist and get inverted inside. So I'm just stabilizing it, and now I'm going to go from the side port and try to see that it opens the right way. You can see it's kind of twisted at the back end, and this usually happens when your ICL has not been pulled straight in one go. It usually happens like that, or otherwise it happens if, again, in the cartridge you've kind of let it be loose and then you push it, and then the rear part of it might twist. So it has to be very important that the loading has to be absolutely right, and you have to watch it under the microscope, push it and let it come forward. You have to see that the 3 holes are aligned in one line. If they are not aligned in one line and the ICL is twisted, it's a good idea to just abort it and kind of reload it rather than go ahead with the surgery like that. Now, another situation where we are injecting the lens, and as we inject it, you can notice, and that's what I was talking about, that sometimes, if you are not careful, the ICL has got, it's difficult to inject, so I had to abort it because it was not coming out, and now a small 2 parts of the ICL are actually projecting. The good thing is that because my incision is almost 3 millimeters, in spite of the fact that otherwise I would have probably gone back and reloaded this lens, but here with an adequate incision, I was able to get that still into the incision and still continue with the injection. Otherwise, I would have had to probably abort it, and if this happens to an IOL, you will never be able to do this. With an ICL, I was able to do it because ICLs are much, much more forgiving in this sense that they are much softer and thinner. So I was still able to complete the injection. Another situation where I've managed to do the ICL really well, this is a 3 millimeter incision, but when I decide to close the incision, my main port is leaky for some reason. Maybe it's a short tunnel. So I'm just going to, instead of put a suture there because this is a toric ICL, I'm just going to make a supraincisional pocket and hydrate that. Now, the moment I hydrate that, my incision becomes nice and it seals very nicely. So this I'm just showing you again that I'm making a supraincisional pocket there, and then I'm going to hydrate that. Just see here, I'm just going to hydrate it. Now, I don't need to suture these wounds, and you can see with the trip and blue test that there is no leak now. So this works really well, and you can get away without, even for toric IOLs, and also today for a lot of my pediatric patients, I just make the superincisional pocket. Now this is a very high vault, 1.39 millimeters that you can see. So this is going to cause problems because this might lead for angle closure in the periphery and also pigment release and optic capture. So you have to be careful about these because this will cause IOP spikes and pigment dispersion, etc., and maybe glaucoma. And then also very low vault can cause ICL rotation, and of course a cataract formation may happen. So you have to be very careful with both these situations, and a totally different talk would be on how to assess the vault and how to plan the vault. So now you can do vault prediction. This is a decentered ICL because it's again a small sized ICL. It's kind of sunk below. It's like the sunset syndrome kind of a thing. So these ICLs again have to be brought out because they will keep rotating, especially if it's a toric ICL. This won't work for long with this patient. Now this is the non-centraflow old lens. This is a typical kind of cataract we used to get, and some of these patients are coming in now. Some of my patients I operated like 17, 18 years back with the traditional ICL with the older design. They now come back with a cataract, and you have to watch out for these, and they will of course need intervention. And all you have to do is bring the two haptics out of the bag of the sulcus, and just you can use a dialer to catch the hole and pull them out, or you can use a manipulator and then put them on axis with a liberal incision of about 3.2 millimeters, and then use the forceps and just tug on it and it comes out. So but incision should be adequate. If it's too small, sometimes these very old ICLs, they will break as you're bringing them out piecemeal. They'll come out piecemeal because the material of the ICL gets denatured over time. So I've had one or two situations where my incision was small because I wanted to do a cataract surgery after that. So I didn't want to make it more than 2.5, 2.6, but the ICL just crumbled as I was explanting it. So going on, this was a patient who came to me with both eyes done by one of my colleagues, and then patient said that one eye is doing great, but the other eye, my vision is gradually going down, I'm not seeing well. And he had gone back to his surgeon 2-3 times, but maybe because they did not have an OCT, they may not have picked up that the ICL was inverted, and patient was going around for almost 15-20 days like this. I told them to immediately get it explanted. The patient went back, got it explanted, but then came back after a week with a situation which was bad. This was the situation. The cataract had punctured. There was a fibrotic ring, and it was a partially absorbed cataract now, 1 month post ICL. So it's very important that we see on slit lamp and maybe on OCT whether our ICL is right side up, because the vault, of course, all of us do monitor, but we cannot allow. I think an OCT is invaluable, and even a simple OCT nowadays comes with enough power to scan to capture the phakic lenses. One of the big indications for monitoring the vault is to manage these, and I think I'm going to run out of time. So another way that I do is that I can see these on intraoperative OCT. You can see here again, I was injecting. Now obviously I knew that I had got the ICL upside down as it opened up, but just for demonstration I showed that the intraoperative OCT is showing that the ICL is upside down. So again, we nowadays do vault assessments on table, and if we find that the vault is inadequate, I can do an ICL exchange right on table. In fact, we've now been doing a study with one of the companies for the last 6 months where we now order one size up and one size down along with the lens, and if I find that the vault is inadequate, I'll either upsize it or downsize it on table rather than wait for it to be done later on. And I'll just go on with this and try to reach one last case. So this was one of those patients where we had ordered 2 sizes because this was a keratoconus patient, and we didn't know whether the patient will do well with the 12.6 or the 13.2 because 2 different measurement systems were suggesting different sizes. So we ordered 2 lenses for this patient, and we went ahead with the surgery. And if you'll notice here that we implanted one of these lenses and then try to see on the intraoperative OCT, we found that the vault was almost flat. There was no vault. As you can see there, just about 50-100 microns. So on table itself, we decided that we are explanting this lens, brought it out, and went in with the second lens which we had on stock. Of course, most manufacturers will not give you this liberty because it's a big loss for them if they have to re-sterilize or maybe discard these lenses. Then we implant the second lens, and now we have a much better vault. This patient did well. She had keratoconus stable for almost 15 years, and the outcome was great. Patient eventually did well. So I'll stop here because Dr. Sharma has already shown ICL-induced cataract and how to deal with them. And I'll request Dr. Chitra to take up, and I'll request Dr. Rupal to come on stage and prepare for the next talk.
I think we have started routinely checking vault the very next day and a week after, and even 6 weeks and 4 months, because we do see that there is a small difference in the vault. The vault settles down in the lower vault, and sometimes the higher vaults become normal. And it is actually better if it's a vault is consistently high and gonioscopically the angle is closed, we can remove it. But a low vault, because of the central hole, it's best to leave them, because too low a vault, in the removal process itself, we could cause a cataract to happen.
So I'll now invite Dr. Chitra Ramamurthy to speak on her topic, and I'll invite Dr. Rupal to set up her talk on the other podium maybe. And it's already done, then you can join us on the stage, no? Okay. So Dr. Chitra Ramamurthy, again a dear friend and a prolific speaker. She's been chairman ARC and had a very amazing term during her tenure. I think we were busy every week of the 3 years. And she's going to be speaking on OOPS moments in surface ablations.
Thank you very much, Gaurav, for this opportunity. And my due is to talk on surface ablation complication. Now, that's something often enough the topic doesn't come up. And we do know when you talk of surface ablation, it's either PRK or PTK and the earlier LASIK procedure which was done. So what are the challenges in PRK? One is the epithelial healing. Invariably in a normal eye, the epithelium is going to heal in 3 to 4 days' time under a bandaged contact lens. But rarely the epithelial healing can be delayed in certain situations, so we need to keep that in mind, and the rare possibility of an infection. Epithelial hyperplasia is a possibility which has become less because we do have a customizable larger optic zones which are possible now to reduce the hyperplasia risk, because the epithelial hyperplasia occurs when there is a more of a curvature gradient change in the curvature, and of course regression and pain component, and some of these complications I'll discuss. How we have addressed the pain component is by using chilled BSS whenever we are irrigating the conjunctival sac or in between on the procedure. And post-operatively, we always used a soaked BCL in Nepafenac drops and of course adequate lubricants in the post-operative period. And our patients are very much comfortable when you see them the next day. Ablation-relation complications are so minuscule because of the kind of lasers and the cyclotorsion compensation and all. But if very, very rarely a decentration has happened because of an unstable fixation of more than 0.5 millimeters, you could do a topo-guided regularization by enlarging the optic zone, but that is something which I've done long, long back. The main challenge is regression when we are doing an epithelium-based surface ablation. And it has been seen in different studies that the post-PRK regression rate can be as high as 19%. And in thinner corneas, 40% of the eyes have been noted to have enhancement at even 10 years later due to undercorrection or regression. Now, this was a patient with a -7 and a -6 diopters with 2 cylinder. Now, these are cases which I would never do for surface ablation. My cutoff is 5 to 6 diopters. But here the corneal thickness was 515 and the patient was told that they'll have a residual power and they could not afford the other procedures, and in every way the topography was normal and a PRK was done. Patient came after 4 years with a regression of -1.25 and 1. And we looked at the epithelial map, you could see that there was a patchy epithelium, that red area, the patchy epithelium remodeling to an increased epithelial thickness. And this patient was advised to undergo a PRK procedure. Epithelial hyperplasia is essentially linked if you have treated higher parts and if you have made a mistake of using a smaller optic zone, because it is the curvature change at the edges of the ablated area which actually causes the regression or the epithelial hyperplasia to occur. And nowadays, all of us are using 6 millimeter or 6.5 millimeter optic zone. So the epithelial thickness change, it is minuscule. What we need to understand is even 118 micron of epithelial hyperplasia, there could be a 1 diopter of regression. And the reasons for epithelial hyperplasia could be mitogenicity of the limbal stem cells or increased keratinocyte stimulation or cytokine production, inflammation, or a very aggressive wound healing response. Now, this was again a patient with -8 diopter of correction in both eyes, which underwent LASIK, PRK. And the Corvus told us that the TBI was a little on the red. So we told him with all adequate information about residual refractive error to undergo a PRK extra. And he came back after 5 years. 3 years with -5 diopter in one eye and some grade 1 reticular haze. You can see on the sagittal curvature map, there's a central red area, and there's on the epithelial map, those patchy areas of epithelial remodeling. So here what we did was a topo-guided regularization with zero power correction, 3,4-C12 compensation, and regularize the topography. And for that -6.5 residual, after 6 months, we went ahead and did a phakic IOL and took care of his residual error. Corneal haze could be an early onset case, haze within the first 3 months, or between 3 months to even up to 3 years. And the reasons for a corneal haze could be high refractive errors being corrected, large ablation depth, or if there's an autoimmune condition or exposure to high exposure to ultraviolet light, radiation, or vitamin D deficiency. You can grade this corneal haze based on the anterior segment chamber details. We all of us use topical steroid drops for at least over a period of 3 months in a tapered regimen, use intra-op mitomycin C for all our patients, 0.02 for 30 seconds, or even many of them use 10 seconds for every diopter of correction. And we ask them to wear protective glasses for the ultraviolet protection. But if there is early haze, you could treat them with topical steroid drops and NSAIDs. But if the haze is more than grade 2, you could either do a mechanical debridement with mitomycin C or do it with a PTK. This is an extensive flow diagram, but all that suffice to know is treat all these patients with topical steroid drops over 12 weeks, keep calling them every 2 weeks, check their intraocular pressure. And if it is a late onset haze, you have to decide whether it's a superficial haze or a deep haze. Superficial haze, just a mechanical debridement with mitomycin C is enough. A deeper haze, we would have to do a PTK with a PRK to correct the part. Nowadays, we have medications like, it's all in the experimental stage of oral cysteine, 200 milligram tablets, or Saha eye drops or losartan drops, which are known to control the myofibroblast proliferation and take care of the haze. Now, this is -3 diopter refractive error. Patient underwent a PRK procedure and came back after 2 months with an uncorrected vision of 624. He had defaulted on topical steroid drops, and he had the typical patchy epithelial haze. And again, this patient, you can see it on the AIOS2025-IC553-Oops, those patchy areas of epithelial remodeling. So we did a PTK of 90 micron and kept mitomycin C for 2 minutes, and his vision improved to uncorrected 612 vision. Now this is another, and this is how he improved over the period of time. And then the last is the late onset haze, wherein again incidentally in this patient, all we had to do just a PTK and take care. So dry eye I'm not covering. The last, which I wanted to show you, infective keratitis can never be ruled out because we have debrided the epithelium, and we have to do a culture sensitivity and feed them, and appropriate drops can be really vision threatening. And sterile corneal infiltrates can occur because of increased meibomian secretion, and you need to keep them on topical steroid drops, and they all settle down. Ectasia, we know it hardly occurs, but this was one case of PRK classic ectasia where we did a topo-guided regularization with cross-linking. Steroid-induced glaucoma has to be kept in mind. For keratoconus, we also do a topo-guided regularization, but in a decentered cone, and if the patient has good vision, it is better to just do a cross-linking alone, because in a decentered cone, if you do a topo-guided regularization, you could end up with a little myopia being induced, although the cornea becomes more symmetric. So there are a lot of smaller issues which can happen with the PRK also, even with the best of machines. So we just need to keep aware of what are the probable complications and deal them as early as possible. Thank you very much. I would call on our last speaker, Dr. Rupal Shah, who's actually a pioneer in refractive surgery and has had a very major role in even doing the study on the before introduction of SMILE, and she's the right person to tell us the way forward from SMILE to SMILE Pro. On to you.
Is this on? Okay. Thank you, Dr. Chitra, for the invitation to be here. And I will be very brief. I know the next session people are already here. I'm just going to give you a first-hand account of the development of SMILE and where in future it is headed to. I am a consultant for Carl Zeiss Meditech, and I am happy to say that I could be an integral part of development of this particular procedure. So the whole story started in 2006 when Professor Secundo and Dr. Bloom did the first lenticular extraction procedure in Germany. And in 2008, after the publication of 250 eyes, we took the baton and tried to solve whatever was unsolved to get it to the level at which it is today. In 2010, the first commercial sales occurred, and within 8 years, they had 1 million procedures performed across the world. And just recently, Zeiss celebrated 10 million smile procedures done all across the world, which is a great feat. It means that this particular procedure is here to stay, and it has stood the test of time. The initial problem was of only delayed recovery. In our first few eyes also, we were extremely surprised by the accuracy of the results. And at 1 year, more than 95% of our first eyes were within plus or minus 0.5 diopter. We were also surprised by the surgical ease and lack of corneal edema and haze. Of course, since there was no one in the world who had performed single incision smile before, we needed to even design the instruments to perform it. However, we also noticed a long visual recovery period, and that is what we tried to answer. We tried a lot of things. We tried steroid in one eye and no steroid in the other on table. We tried putting a BCL in one and not in the other. We even tried doing a PTK on the bed while we were doing flex procedures and not on the other eye, and yet there was no solution in sight. And, but somehow the solution came into our vision, and we felt that there were some cases which were going to do well the next day. So we went back and looked at those particular videos, and we found that if there were no accumulation of bubble in the center after the first pass, before the second pass would start, then the patients did pretty well. So while there was a different changing scanning pattern, where we were scanning the first pass, which was more posterior from inside out, followed by a side cut, and the second pass would come from outside in, and by the time it would reach the center would have a lot of accumulation of bubbles, as you can see here. So it would go through a very distorted cornea. And therefore, it would, when you remove the lenticule, it was leading to an anterior surface which was very distorted, which was also seen in the topography and in the way in which the patient's eyes behaved. Over a period of time, epithelium would then smoothen out these, and then we would have not an issue, and the patients would regain the vision. We suggested this scanning pattern where we would go in the first pass from outside in, and in the second pass quickly from inside out, and this made a big difference. So even though it was a 200 kilohertz, simply changing the scanning pattern made a eureka moment. So when there were only 65% unchanged or gained vision at 1 week, it immediately went to 83%. And at 6 months, from 94 to 98% had unchanged or gained vision. And this laid the foundation stone for further developments. Simply increasing the frequency from 200 kilohertz to 500 kilohertz meant that everything was going to go on much faster, so the bubbles would not have a chance to really accumulate. There was increase in the spot spacing, improvement in the laser spot quality, and as a result of these interventions, SMILE today is equivalent or sometimes even better to femtoLASIK. And in our practice, just like in many more practices, more than 97% of our eyes reach best corrected vision within 1 day post-op. This is a standard technique. I'm sure you must have watched it. So there is one incision. It can vary from 2 to 4 millimeters. It's very easy now to find the planes. And once you have found the plane, and it's very easy to separate it out because the spot spacing and the energy parameters are very well adjusted. So you just go in with a blunt instrument and make a pass to break all the bubbles. bridge between the bubbles. This is the anterior portion getting separated, now the posterior portion getting separated. And once you have a free lenticule inside, you can just grasp it at the edge and remove it through that small incision, leaving the cornea smiling back at you. Getting all the remarkable aspects of SMILE were the predictability, accuracy, and stability of the treatment, which has not really changed. And more than 98% of all eyes are within plus or minus 0.5 diopters of intended correction today. So the current focus is on increasing the surgical ease while maintaining the speed of visual recovery. And the ultimate idea is to have a free-floating lenticule which can simply be pulled out of the stromal pocket. But creating a free-floating lenticule requires tighter spot spacing, and more spots would mean more time, and therefore requires a higher frequency laser to maintain or reduce the time for completing the procedure. Therein comes the role of Visumax 800, which has, as many of its other features, a 4-time higher frequency. And along with that, it also has an easy cyclotorsion alignment as well as central line system for easy centration. This has led to the procedure getting done within 9 seconds. So chances of suction losses are much less. And there is also a potential for easy lenticule dissection. Improved centration is a very important aspect because it is a refractive lenticule that you are creating. So if you have a good centration, it means that you are going to have a good result. And you can also now have centration over the visual axis. And cyclotorsion compensation helps in these higher cylindrical error treatments to get a very good final outcome. So we can look forward to a happier world with SMILE Pro. SMILE Pro enhances visual outcomes for the patients, increases satisfaction leading to happier individuals, a clearer vision improving quality of life, and more individuals experiencing the joy of spectacle-free sight. And that's where the lenticule extraction procedures are headed today. Thank you very much.
Thank you, Dr. Upal, for your very nice presentations. And with this, the refractive session has come to an end, and I hand over the mic to Professor Dr. Kirti Singh for next session. Thank you.